Hello, everyone. We've completed case study number 3, which is about a man named Frank who recently suffered a right CVA. This case study presentation was completed by Ermila, Connie, Gabby, and I. I will first begin our presentation by reviewing what a right CVA is. A right cerebral vascular accident, also known as a stroke, is the interruption of blood and oxygen supply to the brain and is the leading cause of disability in America. The most common type is an ischemic stroke, which is caused by a blockage of the artery, typically from plaque buildup. Another type is a hemorrhagic stroke, which is caused by a ruptured blood vessel in or around the brain tissue. The internal carotid artery supplies blood to the anterior portions of the brain and branches into the anterior and middle cerebral artery. The middle cerebral artery is most often affected during a stroke. These strokes typically result in the following deficits: hemiplegia of the contralateral side, visual field impairments, apraxia, poor judgment, impulsiveness, behavioral abnormalities, depression, aphasia, short-term memory loss, occipital headaches, and hemisensory loss. With most of our patients, safety is our top priority during treatment sessions, as well as when we send them home. We will discuss this more in detail later in the presentation. In addition to the previous deficits listed, the treatment diagnosis that I will be talking about is one that represents the injury or condition that you as the therapist are treating. For Frank, and specifically for this case study, we will be addressing his left neglect, which is not to be confused with visual impairment, but a lack of awareness to his left side. Additionally, his hemiplegia to his left side, upper extremity, and lower extremity that results in deficits that impact his ability to participate in his occupations effectively. Now that we've reviewed Frank's admission diagnosis, let's get to know Frank a little bit more. Following the OT process, I will begin with the occupational profile. Frank was admitted to a rehab hospital where he will be for the next 3 weeks to receive rehab services from occupational therapy, physical therapy, and speech. He is a 68-year-old white male who has a history of diabetes and coronary artery disease. He lives with his wife in a ranch-style home with 5 stairs in the front and a garage detached from the house. He recently retired from the Postal Service and enjoys being active in his community and participating in his hobbies and interests. These include attending a weekly bowling league, spending time in his garden, and woodworking, as well as traveling with his wife. Frank's wife most often fixes his food and completes the household chores, while Frank consistently makes her breakfast and coffee most mornings. Frank also takes care of the household maintenance tasks. Upon discharge, his goals are to return home and resume all of his hobbies. Now I will review the analysis of his occupational performances. So upon observation and completion of evaluation and assessments, Frank displayed the following: no active range of motion or sensory deficits in his right upper extremity, which is also his dominant hand. He demonstrated, however, passive range of motion deficits in his left upper extremities, specifically in shoulder flexion, shoulder abduction, and elbow flexion. His muscle tone in his upper extremities, neck, and trunk scored a 2 on the Ashworth scale and a 1 in his lower extremities on the Ashworth scale as well. Strength was not tested because of increased tone. Frank also demonstrated left hemiplegia, left neglect, and dressing apraxia. Frank's difficulty in completing bathing tasks and dressing tasks due to these conditions have significantly impacted his ability to perform in his occupations. He also ambulates with a hemi walker and requires assistance in this area as well due to his poor balance, and specifically contributes to his lack of independence in his IADLs and ADLs. In addition, Frank demonstrates good humor and self-efficacy. However, due to his injury, Frank shows a lack of insight to his condition and therefore poor safety awareness. These are the following measurements of his active range of motion in his left upper extremity. These measurements will be taken throughout the treatment process to track Frank's progress. What we see here is limited range of motion in his shoulder, elbow, and wrist. We also see the preservation of pronation and finger range of motion that we can use to our advantage during treatment sessions. After collection of data and analysis of his occupational performances, the occupations that have been prioritized in the rehabilitative process are as follows. His ADLs, specifically addressing bathing and functional mobility. His IADLs, taking care of household duties and helping his wife. And lastly, his leisure interests, traveling, gardening, woodworking, and bowling. His goals are to return home and resume his hobbies. That was also an important contribution when selecting his occupations to work on in treatment. Frank's deficits and the resulting impairments on his participation in an occupation are as follows. First, Frank demonstrates cognitive deficits, such as poor attention span, poor insight and judgment, and safety awareness. This may compromise his safety, impact his motivation to engage in treatment, and delay progression towards goals due to the difficulty in learning new tasks. Next is his left side neglect, meaning he ignores the left side of his body, which increases the risk for injury, difficulty with ADLs such as bathing and grooming tasks. Next is the hemiparesis and plegia he experiences on his left side. This results in postural instability, poor bilateral integration, impaired mobility, and decreased independence in his ADLs and IADLs. Dressing apraxia is also an impairment that Frank has, which results in his inability to dress himself and difficulty learning new tasks and techniques to be able to dress himself. Lastly, Frank suffers from somatosensory deficits, which increases his risk for injury and difficulty with motor performance and planning. These deficits listed previously impact his ability to effectively and efficiently participate in self-care tasks without some level of assistance. Upon learning about Frank's leisure interests, we brainstormed and came up with a few intervention ideas that incorporate these interests. So again, to review, his following hobbies and interests are traveling, gardening, woodworking, and bowling. So during the intervention phase, to address his upper extremity functioning through weight-bearing, range of motion exercise, and strengthening, we thought that gardening in a one-to-one session or group therapy session was a great idea. Additionally, woodworking or using tools to unscrew or build simple objects would also be a great idea. Another idea was just a simple bowling activity in his room or during a group therapy session. To address his left side neglect, we thought in order to target his traveling interests, we would use a map to also encourage his visual scanning techniques. Moving on to Frank's performance patterns and how his stroke has impacted these areas are as follows. Frank is a husband, a father, a retiree from the Postal Service, and a friend and bowling team member. How his injuries have affected these areas are he is unable to assist in home maintenance tasks, his difficulty performing as a bowling team member, difficulty in community mobility, participating in his hobbies and interests after retirement, and engaging in intimacy in his marriage relationship with his wife. To assist Frank in resuming some of his roles, we've come up with a few ideas. First, we would begin with task-specific training, which aims to improving component skills of selected tasks through goal-directed practice and repetition. This would also target some of his activities that he's most interested in, and also this would encourage engagement in those activities as well as motivate him. We've also thought to provide community resources and support groups for upon his discharge, and also teach him to use adaptive equipment within the hospital and outside of hospital, and also recommend certain equipments that he can use within his home to assist him in performing the roles that he needs to while he is at home. Some of his routines prior to his CVA and current impact on his routines due to his CVA are as follows. So he occasionally shopped with his wife at the grocery store. He participates in weekly bowling leagues, and he routinely engages in home maintenance tasks. And then every morning he would provide breakfast and make his wife coffee as well as lunch at home. To better assist Frank in resuming his routines, we felt that incorporating weight-bearing activities as well as range of motion strengthening and tactile input, as well as bilateral engagement of his upper extremities during the performing of tasks, would better assist him in resuming his routines, as well as creating morning checklists and other checklists in other areas to address his cognitive deficits, specifically his memory. Now I will move on to the 10 key performance skills that are negatively affecting Frank and his participation in his occupations due to his injury. He has difficulty with stabilizing, reaching, bending, gripping, and manipulation, as well as coordination, specifically in his upper extremity on his left side, and then also difficulty with his static and dynamic balance, sustaining and attending to activities, discrimination between objects and items, and organizing, processing sensory information, as well as navigating during ambulation. So now I will address the 10 key performance skills that are Frank's strengths and that we can use to our advantage during therapy sessions. A lot of them rely on the social interaction skills he's maintained, which are speech production, approaching and engaging in conversation, replying, speaking fluently, taking turns in conversation. He's able to match language through humor. And then additionally, in his motor skills, he's able to reach with his right upper extremity, as well as grip and manipulate with his right upper extremity. And then he's still able to use items as they're intended. So based on Frank's performance skills that we just reviewed, this is one example of how we as therapists would set up Frank at the sink for a bathing task to increase his awareness of his left side and address his left neglect. The OT can sit on the left side of Frank. Objects may be placed on both sides of his visual fields or just on the left side, so he has to address that area of the environment. And we would have Frank use his left hand as much as possible, providing hand-over-hand assistance as needed. And then max verbal cues may be needed and physical assistance due to his left neglect, and also just to encourage his visual scanning techniques that hopefully that he's picked up on and learned throughout the intervention process. And then while performing his ADLs, specifically at the sink or while he's performing bathing or grooming tasks, we would most likely incorporate adaptive equipment to address the weakness he has been experiencing his left upper extremity and lower extremity. So we would recommend a bathing mitt as well as a long-handled sponge.
As we work to address Frank's left side neglect during his ADLs and other activities, we've come up with a few intervention suggestions listed here. Weight-bearing activities through the left upper extremity would be really good to reduce any tone that Frank may have in the left upper extremity, as well as provide sensory input. Weight shifting activities will really help Frank reduce tone in his trunk, as well as aids with transfers. Placing objects on the left visual field for Frank and making sure to cue Frank to scan to the left side and educating him on visual scanning techniques. Communicate to Frank on the unaffected side, so on his right side, making sure that he hears us clearly and is paying attention. Activities involving trunk rotation or bilateral movements, task-specific training, CIMT or constraint-induced movement therapy, and mirror therapy. Here we've listed some environment setup that we want to maintain during Frank's intervention. It'll be important to place necessary clothing items on the left side of his closet and his drawers. That will really force Frank to look to the left side where he has that neglect. Placing grooming items on the left side of the sink for the same purpose. Also encouraging crossing midline. We want to decrease distractions and decrease clutter in the environment. That might mean turning off TVs and radios that he's not actively listening to or watching. And we definitely want the room to be well lit, so making sure the lights are on during his activities so he can see properly. As we work with Frank on his dressing apraxia, we will first problem solve with him. Helping him distinguish right from left and front from back on his clothing will be important. Incorporating intervention strategies for his right and left side discrimination, as well as practicing reciting the right and left while interacting with his own body, so having him practice out loud. Position his garments the same way each time. It's really important for Frank to get used to a specific routine. Creating labels that indicate the front, back, left, and right sides as well, or even just visual aids that give him a step-by-step instruction sheet with pictures. So instruction sheets, like I just mentioned in the previous slide, will be really important for Frank with visual aids. So this will help him remember steps for toileting, washing his hands and face, brushing his teeth, grooming his hair, and dressing. These are his ADLs to help him get back to his normal routine and gaining more independence in his life. We will show these at the end of the presentation. So some activities that Frank used to do prior to his stroke were kind of getting breakfast ready in the morning for him and his wife, and making coffee as well for the both of them. So this would be something really great to incorporate in his therapy sessions at the rehab hospital. It's a familiar activity for him, so it could be motivating for him to get back to that routine. And the task really helps Frank resume his role that he had, it continues to have as a husband for his wife, and kind of help take care of her as well. It encourages the maintenance of these routines and targets various deficits in one activity, such as using the left upper extremity, visual tracking, and attention. So even something as simple as making coffee requires several steps that we can go through with Frank and help him understand what best ways to do this for himself and his wife. And of course, this is task-specific training. As Frank gets back into the kitchen and doing the things he likes to do for himself and for his wife, we have come up with a list of safety measures for him to be aware of. One is stove use. No reaching across the stove to control the temperature knobs. This will be important, especially since Frank has some sensation impairment. He needs to be able to regain that ability to feel the difference between hot and cold. So he'll be utilizing oven mitts and hot pads so that he doesn't burn himself. For knife use, to grade this activity down for a meal preparation, we would recommend pre-sliced fruits. And then once he's able to, get a little bit more advanced in his therapy or even at home, then he can move up to a spiked cutting board that'll hold the food in place while he uses his right dominant hand to cut and peel vegetables. Definitely storing the knives blade down will be really important. Cord management so that there's nothing to trip over, nothing that will cause any fire issues. And then when he's walking in the kitchen, ambulating across the floor, we need to make sure that there are no rugs or mats in the way, and we don't want any wet surfaces for him to slip on. Here's a list of some considerations to take into account for Frank's room that the staff should be educated on. We want to keep some important objects to his right for easy access. Among those would be the call bell for nursing, his urinal, the television remote, and some other items he might use very frequently. We want to use simple instruction sheets on how to use the items placed in his room that might be assistive equipment for Frank. Visual aids to remind Frank and the staff of his current deficits, and proper bed positioning techniques For the staff, a visual aid would be a great way for them to position him properly with pillows to ensure his comfort and prevent contractures on the left side. Our client factors for Frank, just as a reminder, are that his neurological deficits are he has a left hemiplegia with left side neglect, poor attention span, safety awareness. He has perception issues. He has difficulty in figure round, spatial relations, impaired left and right discrimination, sensation impaired for light touch, and sharp and dull, impaired stereognosis in the left. So some interventions we will do with Frank to reduce his tone, we kind of touched on it earlier, were the weight-bearing activities to reduce that tone in the left upper extremity as well as his trunk. So we can do these by having him weight bear on the left during ADL activities at the sink, while completing the activities such as brushing his teeth, combing his hair, making a simple breakfast, lunch, or snack in the kitchen by weight bearing through the left and then doing the activity with the right hand, potting a flower or a plant, and sanding a piece of wood. So these are all things that Frank has done in the past or he likes to do and wants to get back to doing. So we can incorporate these weight-bearing activities through his wants and needs. Splint fabrication will be really important for Frank as we want to create a hand-wrist orthosis to reduce his upper extremity tone and prevent contractures. A resting hand splint would be a great splint for him to use anywhere from 2 to 4 hours a day and possibly overnight, making sure that he's properly positioned in bed. This splint would maintain a 20-degree extension in his wrist and slight flexion of the MCPs of his 4 digits and a relaxed abducted thumb. So Frank's cognitive and perceptual deficits really create a challenge for him to dress properly due to the impaired left and right discrimination, as well as front and back. He needs help with differentiating the neck from the sleeve holes in his shirts. So currently he is at a max assist in dressing. He has left side neglect and causes an overall safety concern for Frank, making his occupations challenging, such as bathing, meal preparation, social participation, home management, and dressing. Of course, there will be difficulty in his driving if he wants to drive independently again. This will be something that his physician will need to clear before he gets back to driving. Difficulty in figure round and spatial relations challenges his mobility. Again, a huge safety concern here. And impaired sensation is another safety concern. So he may not feel hot or cold temperatures while he's eating or cooking in the kitchen. Some interventions to improve Frank's cognition and his perception will be functional activities that he enjoys. So planting some flowers will really help him focus on crossing midline and engaging that left side. Assembling a wood creation, which is one of his prior hobbies, will really help him use some bilateral movement of the left and right upper extremities, or even following a recipe card to make a meal or snack for himself and his wife. Some preparatory activity and occupation-based intervention are education on safety and precautions and strategies, and performing assessments to measure his progress of cognition and perception. Here we've listed some primary safety concerns that we have for Frank. These will be addressed with his wife during treatment sessions, as well as within the interdisciplinary team with all the specialties that work with Frank. And among them are visual tracking to the left side because he has left neglect. He's at fall risk because of poor mobility. figure grounding and spatial relations. We want to prevent injury of that left side because he has impaired sensation, especially when he's performing his meal preparation ADLs, as well as doing some skin integrity checks to prevent skin breakdown. We want him to protect his left side and manage any other comorbidity he might have as well. Psychological support will be very important for Frank. He will have a lot to deal with as his abilities have changed and decreased as a result of his stroke. So, developing and practicing coping skills will be great for him to manage his emotions, manage his new way of life as he continues to recover. So we might suggest a support group for Frank and maybe involving him in a group of people who've had a stroke or have had similar experiences and had positive outcomes. And increasing his self-efficacy by implementing just right challenges into therapy treatments. We want him to be involved and really feel the right amount of support and challenge during his sessions. Here are some environmental adaptations that we've come up with for Frank within the home, the bathroom of his home, kitchen of his home, and his bedroom as well. In the home, in general, we want him to remove clutter from the floors and any rugs that he might have, area rugs or hallway rugs. We want him to use a ramp instead of stairs to prevent falls. In the bathroom, tends to be a very dangerous area of the home. So we want Frank to have a shower bench during showers, a long-handled sponge for bathing, and grab bars, of course, to help with stability and transfers during bathing and toileting. In the kitchen, we want him to put all of his frequently used items in one easy-to-reach place so that he's not having difficulty finding them. A spiked cutting board that we mentioned earlier. And then the bedroom, we really want Frank to utilize the pillows that he may have for proper sleeping bed positioning. Since Frank is able to communicate effectively with his therapist, his family, and other caregivers, we noted that he's not the right candidate for a tablet assistive device to help him resume ADL activity. However, we have recommended a few items for Frank, which would be the shower bench, Hemi walker to increase functional independence and safety, the spiked cutting board, and the resting hand splint orthosis are among the few we've recommended.
It has been noted that Frank has been using lots of humor throughout his treatment sessions, and we had determined that this is a way that he can self-regulate and is a coping strategy for his. Humor is one of his personality traits, so it gives him a sense of normalcy to what he was prior to his incident, as there's a lot of change in his function. This is a way to create joy and just get him feeling more comfortable in his current state. As OTs, we can respond to his humor by engaging in jokes and play to create a positive attitude, encourage Frank. Of course, we stay professional, but this is a way that we can build rapport with him. And of course, we use our clinical reasoning and judgment to determine whether he is in too difficult of an intervention, if it needs to be graded down to be just right challenge. Some potential concerns that Frank may have related to his loss of function are decreased independence in his occupation, such as self-care activities, participating in some of his leisure activities that he enjoys, as well as social participation. Not necessarily that he has an impairment to socially participate, but that he may feel uncomfortable since he is adapting to his new body function, maybe a little bit embarrassed or discouraged. And then just overall, Frank may be concerned about returning to his quote normal, what he was before his stroke, and that when he can return to his desired and needed occupations as he did previously.
while educating Frank, it would also be important to educate his wife, but of course we would need that approval from Frank first before we included her. But it would be very advantageous for us to do so because it has been noted that they have a strong marriage, and also Frank plans to be discharged from inpatient rehab to his private home where he lives with his wife, who has committed to be his primary caregiver. We would be informing them of things such as safety precautions, ADLs, functional mobility, transportation, and expected occupational performance and participation. So all of these would be important to verbally communicate, but also provide them with really quick reference guides. It'll be concise information that they can reference at any time. It'll be also very important that the interdisciplinary team would collaborate by reviewing these important information. So while Frank is in a PT session or OT session or speech, that they would be reiterating the safety precautions so he can understand just how important they are and also to be able to remember them. As for Frank's social supports that we can use during his recovery process is first and foremost his wife, who is there by his side, very committed to him and being there to help achieve his goals and make sure he is at his optimal health and well-being at all times. His friends that he worked with at the post office are great for socialization and participating in their weekly bowling activities, and his neighbors are great for support, possible transportation help, and another outlet for socialization. We determined that the rehabilitative frame of reference would be the best for developing Frank's intervention plan for the following reasons. Rehabilitative frame of reference is focused on restoring health through training and therapy after illness, so after Frank's stroke. It'll focus on Frank's abilities rather than his disabilities, and the focus is to regain function and to utilize sensory motor and biomechanical approaches, which is important for all the neurological deficits he is experiencing at the moment. And then below right here is scholarly articles that we have found that supports the rehabilitative frame of reference. As for a frame of reference to use for remediating Frank's neuromusculoskeletal deficits, we determined neurodevelopmental treatment was best, also known as NDT, because it focuses on regaining movement through facilitation and sensory input. And this is best because Frank already has great self-efficacy and motivation, and so being a facilitator as the therapist instead of a complete doer is going to be great for Frank to thrive. Also, this NDT considers movement quality and effectiveness through a variety of client-centered techniques. So this is an approach, not a method, which allows us to change how we incorporate NDT. So since Frank is really interested and enjoys gardening and woodworking and bowling, those are some activities that we can start with to incorporate NDT through, and that is great for staying client-centered. As noted in these articles below, it is most effective when used in combination with other interventions and treatment, so it's important to recognize that. We have discussed a lot of Frank's deficits already, but this is just an extensive list to be aware of. Some of the primary concerns is his left hemiplegia, left neglect, poor safety awareness, as well as poor attention span. He has poor dynamic sitting balance and standing balance, and some other things listed here, which all impact his occupational participation and performance. Some of Frank's strengths are his humor and self-efficacy, which is great because he maintains interactive throughout treatments, makes them more enjoyable, which increases the chances for him to fully participate and gain the most from his therapy. He does have a supportive environment, which is his wife, who's very involved and committed to be his primary caregiver 24/7. His previous active lifestyle before his stroke is great motivation to work in therapy, stay consistent with his home programming, because he desires to get back to that active lifestyle that he desires. And he is right-hand dominant, which is beneficial because his right CVA affected mainly his left side. He has left hemiplegia, so he still has pretty much 100% strength in his right dominant side. And then also his last strength is this, that he is compliant. So this is also just increased likelihood to attend all treatment sessions at all times and participate fully within therapy activities. Some functional assessments that will be administered throughout Frank's stay at inpatient rehab will be the quality indicators, Barthel Index, and Stroke Impact Scale, which we will go into further individually. So here is the quality indicators. This is just a really great resource for therapists to determine a patient's function level. 6 is going to be independent and 1 is dependent. And this is used in inpatient rehab and beyond. The quality indicator scale offers codings, such as listed here, for reasons that an activity may not have been attempted in evaluation. And this is very important as therapists, that we document any reason that a treatment session has not occurred, that a part of an evaluation was not attempted, and this is to protect the therapist from any potential lawsuits, and it offers clients an explanation of why certain goals are not being met. The Barthel Index is another assessment that addresses areas of personal hygiene, bathing, feeding, toileting, stair climbing, dressing, bowel and bladder control, ambulation, and transfers, which are all listed here. And you can see the scoring is rated from 1 to 5, and the Barthel Index gives us an idea of how much functional assistance is needed and can show us progress that is being made. It will also help us determine whether or not our intervention is being effective and is improving in these areas, or if we need modifications to our treatment plan. The Stroke Impact Scale is very unique and important to administer because it measures the client's perception of functional ability, and it is specific to the stroke population. So this is very important for us to administer with Frank. As you can see, this assessment includes functional activities within the domains of occupational therapy, such as ADLs and IADLs. And this assessment focuses on how the client feels and how they're progressing. So it emphasizes a core component of our profession, which is being client-centered. These are the goals that we have set for Frank, and determined that the long-term goals will be 3 weeks, and the 2 short-term goals for each long-term will be the duration of 1 week each. And this adheres to the norms of inpatient rehab stay. First, we want to focus on Frank's poor dynamic sitting balance, and then for our second long-term goal, we focus on his left side neglect to improve his safety awareness, which we have prioritized both of these as one of our main concerns that we want to address. We, of course, have implemented measurements and levels of assistance within these goals. There is a potential for Frank and his wife to have unrealistic long-term goals for his rehab stay, and ways we can address this is by explaining what Frank's body has gone through. So through his stroke, explaining what is happening neurologically in his body and the normal recovery process. We can explain how we have determined goals using the SMART criteria, which allows them to understand what areas we are targeting, and then also the time frame we're expecting for them to recover. We also need to explain the benefits of inpatient rehab, and that it is very important that he stay, and it is good that he has been admitted. But also we need to be transparent that this treatment is not going to be complete, and it's not going to be an instant recovery. We need to remain encouraging while communicating realistic information and expectations at all times. We have listed some obstacles that Frank may endure while reaching his long-term and short-term goals. Several of these we have discussed, but some new ones are Frank not being in his natural environment. Then he also may experience some sleep deficiency due to it not being his own bed, his own home, being uncomfortable. Maybe nursing comes to check on him in the evenings. Having multiple therapy sessions in a day in inpatient rehab. Having PT or speech before occupational therapy may lead to loss of energy and not being able to participate as fully. Also, new medications may have adverse effects that may make him feel lethargic or nauseous, or they may have positive outcomes. And OTs need to monitor that and note it to nursing and physicians, as well as his comorbidities, coronary artery disease, and diabetes. We need to be monitoring at all times his blood sugars, as well as chest pain and shortness of breath. And if anything occurs, that we will immediately stop that intervention session. As for CODAs, they can play a great role in Frank's assessment and intervention. During his evaluation, they can assist by administering assessments. They can administer these assessments, however, only the OT can analyze the findings. And then for CODA's role in intervention planning, they can collaborate with the OT when planning and discuss observations and things that may be really great for goal setting. However, the OT does make the final decision in treatment planning. As for intervention sessions, the CODA can implement intervention and treatment sessions by themselves, and they can report information to the OT that the OT will later document. The CODA can also suggest treatment plan modifications to the OT if needed. So if Frank is progressing at a quicker rate than anticipated, or if he isn't quite reaching the goals that they thought, then the CODA can suggest modification to the treatment plan.
Next, we will talk about some other assessments we can administer that have different outcome measures. These should look familiar to you, but it is beneficial to refresh our knowledge on how we can use our scientific and pragmatic reasoning to apply these assessments in the clinic. They are the Modified Ashworth Scale, the Montreal Cognitive Assessment, or MoCA, the Activity Card Sort, and the Executive Function Performance Test, or EFPT. We will do a broad overview in the following slides. The Modified Ashworth Scale assesses tone and spasticity. It focuses on motor areas and evaluates the client at the body function level. Frank scored a 2 throughout his left upper extremity, his neck, and his trunk, which is indicative of more marked increase in muscle tone throughout most of the range of motion. His lower extremities, however, received a score of 1, which is a slight increase in muscle tone manifested by a catch and release at the end of the range of motion. This tone could contribute to Frank's poor dynamic balance, as well as difficulties with upper extremity gross and fine motor movements. By understanding how Frank's spasticity presents, this will give us an idea of how this client factor may affect his function, what we need to do in order to address this problem and improve his performance skills, and how to monitor his progress. The MoCA is a quick screening tool that has great sensitivity for detecting cognitive impairment. It assesses memory, attention, visuospatial abilities, executive function, language, and orientation. It focuses on cognitive areas and also evaluates the client at the body function level. The bolded impairments here reflect what cognitive deficits Frank is currently experiencing. By quickly determining how Frank's cognitive function is affected, the therapist can create an appropriate treatment plan that addresses these areas and improves his safety awareness. The activity card sort addresses levels of occupational participation over time. In Frank's case, this is before and after his stroke. Again, this evaluates the client at participation level. This will help to describe Frank's occupational history and how often he participates or participated in them. This will help identify activities that were potentially lost due to his stroke,
and provide a client-centered approach to intervention. Because he is in inpatient rehab, Frank will use the institutional version of this assessment. Lastly, we have the EFPT. This is a standardized assessment that addresses the IADLs of meal preparation, medication management, phone use, and paying bills. This evaluates the client on an occupation-based level. While this does measure executive functioning skills, this assessment also utilizes a top-down approach, which focuses on the performance of basic occupations. In our first situation, Frank has regained active range of motion of 15 degrees in all upper extremity motions. As occupational therapists, we want to modify our interventions to meet the just right challenge and encourage further progress. Some modifications would be to begin constraint-induced movement therapy, where Frank's unaffected arm will be restricted in order to promote use of his affected arm. This will also involve repetitive and structured practice to improve his function. Because most functional activities require bimanual involvement, implementing bimanual task training will help Frank to further improve his range of motion during functional tasks. Lastly, we must grade the tasks up to increase Frank's challenge. This could be giving him less time to complete a task or removing therapist's assistance or adaptive equipment. In the next situation, we walk into Frank's room in the morning to work with him on ADLs and find him in bed with the bed rails up, but trying to climb over them. He already has one leg over the bed rail and is trying to get his left leg over now. What would we do and why? The first thing we want to do in this situation is ensure Frank's safety. We can help him place his leg back on the bed and put the bed rail down if needed. We also want to reduce fall hazard by making sure Frank is properly supported if he does need to get up. We can also remind him to ask for professional assistance in the future and show him where his call button is. We also want to assess cognition. We know that his safety awareness and judgment is impaired, so we want to make sure that this does not happen again. Lastly, we want to make sure we document. We know that if we didn't write it down, it didn't happen. It is our responsibility to make sure that there are no doubts in our quality of care and that we report objective safety concerns, especially if he did get injured. Through accurate documentation and making necessary adjustments to care, we uphold our core OT principles of beneficence, non-maleficence, and veracity. During an intervention session in the OT kitchen, Frank is making a cup of instant coffee. He turns on the stove, gets the kettle, and takes it to the sink to fill. He starts the water, notices a sponge, and starts to clean up the area around the sink itself, and the outside of the cabinets around the sink. He has forgotten the stove and the kettle, and has left the water running for 5 minutes during his cleaning. We think that the cause of this behavior is Frank's poor sustained attention and his poor safety awareness due to his cognitive deficits. We would refocus Frank by giving verbal and visual cues. So we could first start off by asking Frank if there is something he needs to finish before he cleans up. And if he still doesn't remember, we could tell him that the stove is on and that the kettle is filled and ready to make coffee. We could also give him a visual cue by showing him the kettle to refocus him to the task. To adjust this activity for future use, we can remove distractions and unnecessary kitchen items to help maintain his attention. We can also place the kettle next to the sink prior to starting the activity. Lastly, we can utilize auditory timers and simple visual aid instructions, and all of these options would be grading this activity down for Frank. Frank is in the middle of dressing himself. He has been following a set of cards with the steps for dressing on them with good results. Today, Frank is not attending to the cards. He starts to get up to leave the room, but only has his boxers on. How would we redirect Frank to his dressing task? We decided that we would provide verbal cues and reminders. We would first ask Frank if he's forgetting something and then tell him that he has to put his pants on. We also want to orient him back to the task. We could point to his pants in this case, or we could hand him his pants. During functional mobility, Frank has progressed to ambulating with the hemi walker and supervision. However, he bumps into objects on his left side, like the door frame, the bed, and the dresser. How would we address this during our intervention session? So we want to teach Frank compensatory strategies for his perceptual deficits. We want to make sure that we provide cognitive retraining and training in order to use these strategies. We also want to reinforce his visual scanning techniques to address his left neglect, so we could place items on his left side for him to find. To incorporate his functional mobility during an intervention session, we can create an obstacle course that would require him to implement these scanning strategies. And as always, we want to ensure the environment is well lit and that clutter is reduced to avoid fall hazards. When planning Frank's discharge to home health, we need to have a comprehensive discharge summary that shows his progress over his stay in inpatient rehab. We also want to recommend appropriate services for his continuity of care. Frank would benefit from occupational therapy to improve his gross and fine motor coordination, to improve his dynamic sitting and standing balance, to gain further independence in ADLs, specifically with dressing and bathing, to manage impulsivity and create coping strategies, to monitor transition to home with his new environmental modifications and adaptations for safety. We want to continue to decrease his left neglect and incorporate compensatory strategies. And we want to utilize task-specific repetitive learning to regain and to transfer his occupational participation and increase performance throughout different environments. Physical therapy can also help Frank in increasing balance and stability during ambulation. Speech therapy can also be utilized to improve participation and performance in communication. Therapists should also monitor for dysphagia and prevention of aspiration. Recreational therapy can also provide Frank with social and leisure participation through activities to increase his self-efficacy and wellness during recovery. These service recommendations would be documented here under this portion of the referral. Now we're going to talk a little bit more about home health referrals. Occupational therapists can establish initial eligibility for home health. As we saw in the previous slide, we would fill out our service recommendations. We would also fill out our referral source. So the discharge facility in Frank's case was inpatient rehab. His discharge date. Another important section to note is his diagnosis. So his primary diagnosis was right CVA with left hemiplegia and left neglect. We have pertinent secondary comorbidities. So for Frank, that was coronary artery disease and diabetes. And there's also a section for insurance, depending on what Frank has. And as always, we want to make sure that we sign our document with our credentials. A physician's approval and signature are required for this to go through. To encourage carryover and promote safety and participation, we have listed instructions that we would give to Frank and his wife. We would like to see Frank start a home program, and we would provide him with evidence-based information in the form of easy-to-read handouts, pamphlets, or other resources. We will show some examples of these in the next slide. Some of the instructions we would give would include proper care for his affected upper extremity, passive range of motion exercises, self range of motion exercises, protection and support of the affected arm during bed mobility transfers and ablation, proper positioning in his bed and chairs, safety and functional mobility, adaptive equipment purchasing and use, splinting use and schedule, home safety and modifications, stroke education, community resources, and we want to encourage support group participation as well. These are some examples of instruction sheets with common ADLs that Frank would participate in to regain his independence. On the left, we have bed mobility, and on the right, we have lower body dressing. These are easy to read and include a title of the activity, written instructions, and pictures so that Frank and his wife can visualize the movements needed to achieve these tasks. Thank you.